Hello, my name is Mary Jane Allen Boss, and I'm the Director of Case Management. And today I'm going to talk to you about our case management program at Lourdes Hospital. Case management looks at discharge planning. There's an assessment component, care coordination, care management, and support. For example, in assessment, we look at risk stratification and the case management needs assessments for the patients. Through care coordination, we arrange for services across the continuum of care for providers, outpatient services, and other services. For care management specifically, we arrange home care and home care services such as IV therapy. We also provide information for personal care and domestic needs. We also oversee and assist with patients' transitional care by helping with follow-up appointments with a primary provider. We support the family and the patient with education and other necessary resources. Case management assists the physicians and providers in patient management. For instance, prior to hospitalization, we do assist with pre-certification. During hospitalization, case management will help with discharge planning and concurrent utilization review. Following discharge, we again arrange for services as necessary based on the patient's needs. And of course, we always feel that patient satisfaction is very important to us. We also ensure compliance with regulatory standards. CMS came recently out with discharge planning regulations, as well as the Two-Midnight Rule. Case management, pre-hospitalization, the pre-certification for elective admissions. Authorization from the patient's insurance is required for planned surgery or other procedures. We verify the patient's insurance and we notify the physician's office if different than reported. We also notify the physician office when certain procedures are listed on Medicare's inpatient only list to ensure patient is registered as an inpatient rather than an outpatient, which is very, very important. Case management, utilization management portion. Patient admission status level of care. Admission level of care is determined by the provider with guidance from the case management. It is very important that every admission status must be determined and written by the provider. There are 4 levels of care. There's an acute, and they must meet severity of illness and intensity of service for inpatient admission. Observation status between 24 and 48 hours to observe the patient as outpatient status in the hospital, and within the 48 hours a determination must be made whether to discharge the patient or to admit the patient as inpatient. A social admission is considered a non-acute status. These patients do not meet medical necessity and they're not covered by the patient's insurance. Ambulatory surgery usually requires or may require an overnight stay for postoperative monitoring. Case management, the resource options to avoid unnecessary hospital admissions. Case manager and the social work very collaboratively together to link the patient to the appropriate outpatient resources. This is important to avoid any type of hospital admission when appropriate. For example, when patients come to the emergency room and really do not need to be admitted but may need further assistance or by being assigned to a nursing home, or perhaps having the patient return to home and referring the case for home care or other outpatient services as identified. During the hospital stay, discharge planning is performed by case management to ensure a safe and appropriate plan. Options such as home with home care services, hospice, nursing home in the immediate area or the surrounding areas, rehab services are just some of the plans and options that can occur for the patient. All of these plans and options are based on patient's needs. The patient discharge appeal rights. There are times when patients may not agree with the discharge, and case managers will work with those patients to ensure that the patient's rights to appeal if he or she disagrees with the discharge, or that the patient is notified that he and she no longer requires acute level of care. The case manager will instruct the patient on the appeal process at the time of the patient notification. iPro may contact you for additional patient information as well. Denial management. Payers will review medical records following a discharge and at times will notify the hospital that an inpatient admission was not medically necessary and could not have been done or could have been done at a lesser level of care. Involved physicians may be asked by utilization management to review the denial case and determine if he or she wishes to write a letter to justify the medical necessity, or to appeal the decision, or no further action would be necessary and accept the denial decision. Cardiovascular disease management is also under case management. Lourdes has two cardiovascular disease management. Cardiovascular disease management. The role of the cardiovascular disease manager is to ensure core measures for heart failure, acute myocardial infarct, and CVAs are met. Our cardiovascular disease managers communicates frequently with the providers, particularly the need to add missing documentation for core measures when identified. Patient education is also done by our disease manager, particularly to disease processes, warning signs and symptoms, along with strategies to prevent acute exacerbation, which could lead to readmission. Cardiovascular disease manager also performs staff education regarding current treatment updates. They also do follow-up phone calls to discharge heart failure patients to ensure compliance with patient treatment plan, including medication management, follow-up physician appointments, etc. Outpatient education is also available. We have a Tea Time, which is a patient support program specific to our heart failure patients. And again, the cardiovascular disease managers collaborate with the quality services regarding core measures. Quality care is measured through our core measures specific to cardiovascular disease such as heart failure, acute myocardial infarction, and stroke. Lourdes is very fortunate to have a clinical documentation improvement program, better known as the CDI. One will say, what is a clinical documentation improvement program? It's a team of RNs who work collaboratively with providers and coders to bridge the gap between the data and the documentation contained in the medical record and what is available for code. The CDI has goals. One is to capture complete provider documentation that can be translated into precise ICD-9 coding, soon to be ICD-10, to accurately reflect the patient's severity of illness and risk of mortality through documentation in the medical record, and to support the necessity of the consumption of resources, as well as to support the need for continual length of stay and the quality of care provided. The CDI supports, as with direct patient care, the CDI presents relevant findings to the physician for review through queries, both verbally and written. Queries identify potential opportunities to accurately reflect patient care and the supporting diagnosis by the provider. Written queries are placed in the record, and reminder stickers is also found in the front of the chart. A response to a query, the ultimate goal is within 24 hours. A response should be made to every query, whether you agree or disagree. If you agree, please update the chart to address the queried issue, even if the issue has been resolved. If you disagree, add to the next progress note. Example, a resolved acute respiratory failure. And then you could add to the discharge summary, the patient experienced acute respiratory failure resolved with the specific treatment that was utilized. If you disagree with the query, please indicate on the query form or discuss it with your CDI nurse. How will CDI impact you? The medical record clearly represents the patient's clinical picture, leading to patient safety, a true reflection of the patient and the care provided, accurate coding, and appropriate reimbursement, with fewer denials and accurate provider profiling as well as hospital profiling. The reminders that CDI wishes to share is 1. Always document diagnoses when possible versus symptoms. Always include the acuity of the diagnosis when possible, such as acute, chronic, or acute on chronic, and exacerbation. Remember to include the type and stage when indicated, such as acute systolic heart failure, aspiration pneumonia, acute renal failure, chronic kidney disease, stage 3. Remember, using the words possible, probable, or likely are acceptable terms, such as probable gram-negative pneumonia, possible aspiration pneumonia. Remember to provide ongoing documentation of diagnosis from one progress note to the next and indicate when a diagnosis has been resolved or has been ruled out. Thank you for listening to our case management and utilization program at Lourdes Hospital. We wish you luck, and if you are in need of any assistance of any kind during your time here at Lourdes, please don't hesitate to call the Utilization Management at 798-6113, and someone will be there to help you or refer you to someone else for further assistance. Thank you.